Now, what made that scheme possible was a change in the law in 2006, and this change in the law also made possible the idea of the altruistic or Good Samaritan donor who simply wants to give a kidney, can't direct where it goes, just wants to go to a welcome home. And this is, I think this was the second or third such transplant in the UK, but it was one that we did in Cambridge. The donor recipient are not normally encouraged to meet, but after the transplant's been done, if they both want to, then it's discouraged. And there you can see there was a meeting of the donor and the grandmother who gave the kidney. It does open up, as you can imagine, potential complexities. But there you go. Now this scheme has been surprisingly popular actually, so there have been a total of 32 altruistic donors who've given their kidney to recipients in the UK. They're of widely varying ages. The youngest was 24, the most elderly was 69, although I know in a transplant centre not 400 miles from here, they're currently looking at the potential of an 82-year-old altruistic donor. Better hurry up. Slightly surprising actually, there's been an equal take-up between males and females. So although typically for unrelated transplants is the majority of females, here there have been more male, 17 males, 15 females. The kidneys aren't just to the traditional scheme in the UK for deceased donor transplants, so they just give the best match person. And the recipient's been waiting on average for about 4 years. The cold ischemia time is simply the time it takes to remove the kidney and ship it to the other centre, so the median is 6 hours, although the longest there is 20 hours. I think that went possibly to 2 centres. In fact, I know it did, so there was a bit of an issue there. So this was 1.7% of total wide donor kidney transplants in the UK, and I think, again, it's fair to say that there's quite a rush of people who want to give their kidney. They're obviously screened very carefully. There's a sort of early screen with total madness, and then there's a sort of more sophisticated screen by a psychiatrist and so forth. So they are screened very carefully, and they go through very, you've got to admire some of these people. They actually go make the ultimate sacrifice, and they are very impressive individuals. They have a variety of motives for doing it. Now, just moving on to the last third of my presentation, I just wanted to highlight firstly organ storage, but then expression very briefly. So once the kidneys have been removed, I mentioned already that kidneys from deceased donors have a very high immediate non-function rate, about 50%. So this is there's now much interest in how these kidneys are stored. A lot of this has been driven by the companies who produce perfusion machines, which are pretty expensive to buy, and it's a bit of a niche market, so they're quite arguably overpriced, these things. So there are 1 or 2 studies. We carried out a randomized control study of simple static cold storage, or in other words, putting a kidney in a box of ice, and compared that with the more sophisticated approach, which is putting the kidney on a cold pulsatile perfusion machine and then stored there until it's ready for transplantation. So this was a randomized controlled trial led by Chris Watson in Cambridge. It was done on an intention to treat basis of the sequential design, which actually ended with us stopping the trial well before we got a particular large number of patients, simply because it became clear there was no advantage, as you'll see. The primary endpoint was instance of delayed graft function, and then there were a number of secondary endpoints, as you can see there. So these are the results in summary. The 2 groups were pretty well matched actually. The trial, I should have said, was that from each donor, 1 kidney would go on the machine and go to the recipient. The other kidney from the same donor would go to a box of ice and then go to the recipient. So it's quite nice to the donor characteristics therefore were identical in the two groups. The cold ischemia time was about 14 hours in both groups. As you can see, the delayed graft function rate was no different in the 2 groups. So it was 58% in the machine perfusion, so actually slightly higher in fact than the 56% in the cold storage group. There was 1 case of primary non-function in the machine perfusion group. Graft survival was numerically slightly higher in the machine perfusion perfusion. That's slightly higher in the cold storage than the machine perfusion. And at 1 year, the estimated GFR, which is a reasonable estimate of how well the grafts are functioning, was identical in the two groups. So from this study, there doesn't seem to be in the UK any benefit of the more expensive and potentially technically more demanding process of putting kidneys on the machines. Now there are some issues here. For example, the kidneys weren't put on the machine until they got back to the procurement centre, so there was a bit of a delay there. And you might argue that if we use the machine from the time, literally the time the kidney was taken out of the donor, the results might have been different. So there are issues, but so far as the evidence in the UK goes, there's no advantage. And this is in direct conflict with data from a European study, which suggests that there is an advantage of machine perfusion. So there are some issues there. Now, I showed this slide to my wife as a immunologist, and she said, "Who's that for?" And I said, "For the SARS meeting." She said, "No, I wouldn't show that." For obvious reasons. But I thought it would anyway. So this just summarizes very simplistically the processes that happen from an immunological point of view after kidney transplant. So the key event is the encounter between the T helper cell and the dendritic cell, whether it's a donor-derived cell from the kidney itself or whether it's a recipient dendritic cell that takes up donor antigen. Both pathways are important. The T helper cell engages through its T cell receptor with our antigen. It's the crucial co-stimulatory activity, without which it's likely that the T helper cell will become allergic or unresponsive. So co-stimulation is key, as I'll explain. The conclusion is that T helper cell is the master or director, I suppose, of the orchestra, and it orchestrates all the effector responses which can then go on and damage the graft. All of these are important. So cytotoxic T cells bind to target antigens on endothelial cells, reduce perforin, granzyme, cause endothelial activation injury, activated macrophages, produce TNF alpha, oxide, etc., etc. B cells are key, they obviously produce antibody, and there's now a realization in transplantation that our antibody is just as important as the cellular effector mechanisms, in some cases even more important. So the immune system doesn't have any special weapons to use against transplant, it simply recruits all of the things it uses to defend itself against bacteria. Now, traditionally the approach we use with high degree of success to harness this immune response to prevent graft rejection are the calcineurin inhibitors, namely cyclosporin and tacrolimus, and these have been around now for almost 2 decades in the case of cyclosporin and not far short of that for tacrolimus. They both block calcineurin activity. Essentially, the net result of that is to prevent interleukin 2 and other growth factors being produced. So it stops T helper cells proliferating, it also stops CTLs proliferating, and through that mechanism prevents graft rejection. The problem is, as I'm sure most of you know, is that the CNI inhibitors are particularly toxic, and ironically they're particularly bad for the kidney. So that's why many patients who have a successful heart transplant eventually end up needing a kidney transplant, because these agents are particularly toxic, especially if used at high dose. So calcineurin inhibitors have been the mainstay of immunosuppression for a long time, but they are not without problems. And I think gradually there's now an increasing realization that biological agents, in other words antibodies and fusion proteins, which block more specifically key interactions, key ligand interactions in the immune system, are probably definitely less toxic and probably could be made to be just as effective. I'm just going to mention 3 of these. Co-stimulatory blockade, which is a very exciting area, and I'm just going to touch on that. Anti-CD20 and also anti-CD52. So anti-CD52 is a rat anti-human, it's a humanized monoclonal antibody against a molecule called CD52, which is expressed on lymphocytes, T cells, B cells, also monocytes, and some dendritic cells. It was discovered by Herman Waldman there. Waldman was working in Cambridge, subsequently defected to Oxford, where he's now based. And there many people recognise Roy Kahn, my predecessor, who first used CANPath in transplantation. So CANPath is a profoundly lymphocyte-depleting antibody. It depletes lymphocytes for several months from the circulation, and it also partially depletes, but not so effectively, cells from lymphoid organs.